So a very good morning to everyone. I, Dr. Poonam Joshi, welcome you all once again to our Head and Neck ACTREC academic classes. Our today's speaker is Dr. Amit Joshi. Dr. Amit is Professor and Head Department of Medical Oncology at Tata Memorial Center, ACTREC. Dr. Amit is speaking regarding the role of targeted therapy and immunotherapy, that is a systemic therapy in the management of advanced thyroid cancers. So I would request Dr. Amit to please go ahead with the presentation.
Thank you. So I think with the better understanding of the biology of the various diseases, the disease which were previously supposed to be the not a domain for medical oncologists, gradually the role of a various targeted therapies has come into the picture. So we'll try to just quickly go through these, that how the newer therapies has helped in management of a advanced metastatic thyroid cancer. So beginning with the just a few basic slides, we all know that overall thyroid cancer is not a homogeneous disease, and it has a different variant, which we all aware that differentiated thyroid cancer, which comprises of a papillary, follicular, Hurther cell, and poorly differentiated, and the medullary thyroid cancer, which is supposed to be a part of a neuroendocrine, which arises from parafollicular C cell, and the anaplastic thyroid cancer. So we all know the origin of these three different types of cancers are different, and their prognosis is different in terms of the, and the management also varies. So this is important to understand the biology at in subsequent slide. So three type of different tumor: differentiated, medullary, and anaplastic thyroid cancer, and differentiated further subdivided into the papillary, follicular, and Hurther, that we all are aware of this classification. So just a slide showing the how the thyroid cancer in a patients, what are the major cause of their mortality in due course of time. So there are two curves shown in this. One is the thyroid cancer death in the age wise, and second is the thyroid cancer death as per the histopathological subtype. And if you see the thyroid cancer death as per the age, and this is the probability of that in this axis, and the survival in years in this axis. So if you see the patients who are less than 45 years of age, the probability of dying of a thyroid cancer patient from the thyroid cancer per self is very, very low. So that means as the age advances, the probability of dying from a thyroid cancer in a thyroid cancer patients. So what it means that the patient dies in a young patient of a thyroid cancer, the cause of death is not the underlying thyroid cancer, it is the some other diseases as the age related and other phenomena. And this is another important graph showing the type of the thyroid cancer. So if you see the death in a thyroid cancer patient in a anaplastic, so this upper curve for a anaplastic thyroid cancer. So that means if a patient diagnosed with an anaplastic thyroid cancer, the probability of that from the anaplastic thyroid cancer is in the range of 80%. But in the contrast, patient diagnosed with a papillary thyroid cancer, the probability of, this is the last curve, so the probability of dying from the thyroid cancer in a case patients of a papillary thyroid cancer is very low. So that means it shows the aggressiveness of the different thyroid cancer, the anaplastic being the highest aggressive cancer, whereas the papillary is the most indolent, and majority of the patients who are diagnosed with papillary thyroid cancer may not die because of the underlying thyroid cancer. So this is important for discussion of the subsequent slides. So what are the therapeutic challenge in the management of a metastatic thyroid cancer? So 10 to 15% of the differentiated thyroid cancer result in a recurrent or refractory disease. We all know that majority of them will be cured, but some percentage that stated around 10 to 15% patient, there may be recurrence of the disease, or they are refractory to the radioiodine treatment, and subsequently these patients will die because of their underlying thyroid cancer. So the challenge in a thyroid cancer is to management of these patients who unfortunately are not cured by but fortunately 80 to 90% patients are still cured with the initial surgery followed by radioiodine. So whatever the newer advances has come into the management of thyroid cancer is for this group of the patients. So similarly, how the survival correlates with the iodine 131 uptake in the patient. So and we all know that as the iodine uptake decreases, the probability of survival decreases. So this is one graph showing the as the patients become a radioiodine refractory, the probability or the cure of the patients decreases over a period of time. So what it shows that as the patients becomes radioiodine resistant, the patient needs newer therapies, the further therapies to improve their survival. So now coming to the our main topic, the radioiodine refractory advance. So that what I told you, that the management will be divided into three groups: the differentiated thyroid cancer, anaplastic, and medullary. So the most common and most relevant in the day-to-day second is the management of a radioiodine differentiated thyroid cancer. So we all know that patients who receive radioiodine therapy after their surgery, some percentage of patient will become radioiodine refractory, and even with the increasing doses, the response is not there, and the what we call as a radioiodine refractory disease. And this radioiodine refractory disease is associated with older age, associated with the poorly differentiated tumors, and in the papillary and patients who are presenting with a high FDG uptake in a PET-CT. So these are the patients who have who progresses on the radioiodine at subsequent follow-up. But definitely the number is not very large, but 1/3 of the patient at some point of time in their disease biology will become radioiodine refractory. So whatever the newer advances has come into the picture is for the management of these radioiodine refractory cancer in a differentiated thyroid cancer. So previously 10-15 years back, when there was not much treatment available, when the patients become radioiodine refractory, either a trial of high dose vitamin A being tried to make the tumor again sensitive for radioiodine, and the other chemotherapy which was being tried is the doxorubicin or adriamycin. It is one of the drug which has been FDA approved for this setting, but the response rate is very low. It's only less than 5% patient respond. And as we all aware that the toxicity of this chemotherapy in a patient population where the response rate is less than 5%, so the high toxicity with a very poor QL, the adriamycin or doxorubicin is not the treat, and hardly any, even when there was nothing available, we rarely used the chemotherapy in this subset of the patient. So basically, when after becoming the radioiodine refractory disease, there were very limited options available in previously when the patients become radioiodine refractory, and majority of the patients were used to succumb in next few subsequent years. So then the real change come. What was the unmet clinical need? That in radioiodine refractory disease, the unmet need is to improve the survival of these patients with a good the progression-free and overall survival, maintaining the quality of life of these patients, alleviating the symptom of these patients, and the therapy which is being planned should be well tolerated in these patients. So ultimately, the 20 to 30% patient of radioiodine refractory disease will need some sort of these therapies to improve their quality of life, survival, and to improve and the tolerance of their therapy should be good. So with this, as I discussed previously, so in a medical oncology, so previously the main treatment of majority of the cancer were chemotherapy, but in last 10 to 15 years, the things have changed with the better understanding of the cancer biology, with the better precise selected targeted inhibitors to block these pathways. The medical oncology has come a long way, and with the availability of the newer and newer targeted therapies, the survival of a different, it's not only the thyroid cancer, the breast cancer, lung cancer. So all the survival for a majority of the cancer patients have improved over a period of time with the precision, what we call as a precision medicine, in which we study the various pathways, various receptors which are associated with the tumor progression, various drugs have been developed to target these pathways. Similarly, when the advancement were done in the other cancer field, similarly, the thyroid cancer biology has also been studied in a detail to know why these patients become radioiodine refractory and what are the mechanism to overcome this radioiodine refractory disease. And the way to target of these is the various what we call as a tyrosine kinase inhibitor, the immunotherapy, which are the newer armamentarium in the management of various cancer in medical arms. So we will discuss about this. So and this is another diagram how this. So what I discussed previously, the understanding that how these tumor cells after becoming the radioiodine refractory disease, how they proliferate. So what are the pathways which are responsible for the so the pathway which is being studied mostly is the EGFR targeted therapies, the VGFR pathway. So these are the this is the cell membrane and these are the receptors which are located. So when the tumor becomes refractory, these pathways, they take the signal from the external stimuli and they transmit this by the various mechanism, and ultimately which will lead into the tumor cell proliferation. If we block this pathway, the inside signaling will be blocked and the tumor cell will also get killed in due course of time. So like the VGFR, this is the pathway which is being very commonly targeted in a thyroid cancer and also in the renal cell carcinoma. So these are the drugs which be written here are also being commonly used in the management of the renal cell carcinoma. So majority of the drugs which are being used is not a tumor specific, it's the pathway specific. If there is a VGFR overexpression in the tumor, these all drug will build. So in a tumor which are being highly VGFR expression, all these work. So the best example for a VGFR overexpressing tumor is the renal cell carcinoma, some colorectal cancer, and definitely the thyroid cancer, the differentiated thyroid cancer, where this is the overexpression. So with this better understanding, various drugs come into the picture, and the first drug which is being used to target this pathway was the sorafenib, and then the lenvatinib, axitinib, and everolimus. So that we will discuss how these therapies has integrated into the management. So the basic purpose of showing is that understanding the tumor biology at the time of progression, understanding the pathway, how this work, and then with the availability of the what we call as a protein signaling, the various targeted therapies have been gradually come into the picture in thyroid cancer management. So this is the just which I discussed about the various receptors. So these drugs, sorafenib, which works, so there are various receptors on the tumor cell, and individual drugs works on one or two pathways. Like a sorafenib, it's a pan inhibitor which works on the VGFR inhibitor, some BRAF inhibitor, some this is a platelet-derived growth factor receptor, the KIT pathway, and FLT3 pathway. But some drug will not work, and the reason for, and if this drug works on a many pathway, whether this will be more effective? No. With the availability or the inhibition of the many pathways, the toxicity of this drug, because sometimes some normal expression of these receptors are also seen in the various normal cell of the body. If you block the tumor cells, there may be some inhibition of the normal receptors in a normal tissue, which will lead to the other side effects which are very commonly associated with these VGFR TKI. Like the inhibition of VGFR will lead to the these receptors in the kidneys, normal kidney tissue, which will lead to the hypertension. So the effect of a drug will also have some or other effect on the toxicity profile of this drug, which we will discuss subsequently. So this was the first landmark study in a management of a radioiodine refractory thyroid cancer. This is what we call this as a decision trial. So in a oncology setting, whenever we come with a new proposal of a new drug, that has to be tested in a randomized way, and the best randomized way is in a phase 3 setting. So in an oncological setting, if we come with the data of any drug which is supposed to be working in a phase 1 or phase 2, the ultimate test of any drug, whether it stood the test of the time in a randomized phase 3 trial. So this is a randomized phase 3 study of a sorafenib versus placebo. So at that point of time, there was no standard of care. Placebo can be the adriamycin, placebo can be the vitamin A agent, and the experimental arm of that study was the sorafenib. So this was the question, whether the when in a patient of a locally advanced metastatic differentiated thyroid radioiodine refractory patient, no targeted therapy used, if we give them the sorafenib or a placebo, which one is better? So that was the question which was asked in the decision trial, and sorafenib was used in 400 mg BD, and this was started. And the decision to continue this drug was based on radiological finding. Till the time there is a radiological stability of the disease, the CT scan which was done every 3 monthly or 6 monthly, this drug was continued. So this drug was continued till the progression of the disease, or investigator get decisions. When there is a progression, then whether to continue or stop the drug was the investigator's choice. So this was the trial design, patients of a locally advanced metastatic differentiated thyroid cancer. And this line is very important to understand, that there should be a disease progression in radiology within 14 months. So in a clinical practice, even if the patient has become a radioiodine refractory, but if the disease is not progressing very rapidly, are we is it acceptable to start these therapies just on a simple progression? No, there should be a progression of the disease which within the last 14 months. So there should be, because in a clinical practice we all know that some radioiodine refractory patient may not progress very rapidly. Their disease may be of a low aggressive biology. So some patient might not need the therapy. So ultimately therapy needs to be started when there is a clear-cut radiological progression of the disease in a scan, or patient is becoming symptomatic for that metastatic. For example, if there are multiple tiny metastatic lung nodule of a centimeter size, which is not causing any symptom, not progressing over a period of time, we will not start the treatment. We will just observe. When these lung lesions started progressing on a imaging, then in a clinical practice we consider. So that is, this point is very important in a day-to-day setting, that all patient of a radioiodine refractory does not require immediate treatment. We have to just reassure, we have to do a proper imaging in period of time. When we see that there is a clear progression of the disease or there is a symptomatic worsening, then we start considering, because these drugs are a toxicity, which I will show in subsequent slide. These are the drugs which causes a lot of toxicity, although these are the oral pills, but their toxicity profile is difficult to manage. So we should not make the patient's quality of life deteriorating because of the therapy, not because of the underlying disease. So this is the slide showing the progression-free survival by the independent review. So patients who received sorafenib, this is the solid yellow line, and this is the light yellow line. Patient who received the sorafenib has a better disease control. And if you see the median PFS, that means the 50% in 50% of the patient, the disease remained controlled for 11 months, compared to the patient who received placebo, the disease was controlled. So there is a clear-cut doubling of the control of the disease in patients who receive the sorafenib compared to the placebo. And those who are well versed with the statistical jargon, the hazard ratio of 0.51 is a clear-cut indication that this drug is working, or working much better compared to with the placebo, and the p-value is the point. That means that it's a highly significant benefit in terms of the disease progression or death. So in a statistical terminology, it's a 41% reduction in the disease progression or death in patients of a radioiodine refractory progressive thyroid cancer who receive sorafenib compared to the placebo. So what the trial of this concluded, and the other question, whether there was an overall survival benefit was there or not. So since in this study there was a crossover means those patients who are on the placebo arm, when they were allowed to receive the sorafenib at the time of progression, around 60-70% patients received the sorafenib in placebo arm at the time of progression. So the overall survival has not reached into the sorafenib arm, but placebo patient, because of the crossover, the median OS is around 36.5. So what the trial, these people have concluded that in a patient of a metastatic thyroid cancer progressive disease, who at the time of their radiological progression, when sorafenib was started, there was a clear-cut benefit in terms of the progression-free survival, that is the control of the disease, which was double than the patient who received the placebo, which was close to the 6 months and close to 12 months in the sorafenib. So with this availability of this drug, the FDA has approved sorafenib 4 or 5 years back in patients of a metastatic differentiated thyroid cancer. So now the coming to the toxicity, which I was discussing, why we are very much not keen to start the TKI in any patient of a radioiodine. If you see the grade 3 or 4, so those who are well versed with the toxicity assessment criteria, there are 4 grades of toxicity: grade 1, grade 2, grade 4. So grade 4 is the worst toxicity for any of the associated. So those patients who are, so this is the sorafenib arm and this is the toxicity in the placebo arm. If you see the hand foot reaction, around 20% patients receive that toxicity of that degree compared to patients on a placebo. Definitely placebo will have a very, because it's a placebo, so we do not expect the toxicity with placebo. And if you see the rash, deesquamation, diarrhea in around hypertension, around 10% patient. So the overall toxicity, if you combine, around 30% patients on a sorafenib arm has led to some sort of a toxicity, and this lead to around 15 to 20% patient the discontinuation of sorafenib because of the toxicity. And in a day-to-day setting, when we use sorafenib, the toxicity percentage is much more. Around 30% patient require dose modification. 400 mg BD in our patient population is very difficult to administer. So, although these are the oral drugs, but the toxicity profile of these drugs are very significant. Patient needs close monitoring for their blood pressure, for their hand, foot, skin, and around in close to 30-40% patient requires dose modification. In 10% patient, we need to stop the therapy because of the worsening quality of life in these patients. So this was the sorafenib. So with that trial, the sorafenib got FDA approval, but we all know the toxicity was around 30 to 40% patient developed. So meanwhile, the other drugs have come into the picture. Other better targeted, tolerable TKI was in the place. And the other one which I'm going to discuss, the lenvatinib. So by the time the lenvatinib has got the approval in other drug, other disease like renal cell carcinoma, and since it has a VEGFR inhibiting property, the investigator tried why not to use this drug in the same radioiodine refractory differentiated thyroid cancer. So the same study is planned in a patient who are radioiodine refractory, more than 18-year-old, and patients who have received one prior VGF has also been allowed in this therapy. So that if the patient has received sorafenib first line, their disease is progressing, these patients were also allowed. And similarly, the lenvatinib, the one arm received the lenvatinib, the other arm received the placebo to test whether this drug in the first or second line in our metastatic RCC helps or not. So this trial was conducted in the same design, lenvatinib versus placebo till progression, and the primary endpoint was the progression-free survival. That means how long this drug is able to control the disease from further progression, which was measured in a CT scan. There is a criteria, what we call as a response evaluation criteria in solid tumor. In acronym, it is called as a RECIST criteria. So how long this drug compared to the placebo is able to control the progression of the disease. So comment, and there are certain points which again I wanted to highlight. If you see the inclusion criteria, there should be a measurable disease in the scan so that the RECIST can be applied. And again, the subject must show evidence of disease progression within 12 months. If you remember, in the decision, it was 14 months, but in the lenvatinib trial, so that means the patient should have some sort of a disease, radiological disease progression within last 1 year. So the same sentence, that a stable disease over period of time, even though it's a radioiodine refractory, does not warrant to start the TKI. There should be a clear-cut progressive disease, and there should be a radioiodine refractory, which is defined by this. We all know that iodine doses more than 600 millicurie. There should be more. So that's all other criteria were more or less same. But again, I'm emphasizing the point that both trial have shown, have included the patients who have progression of the disease. It's not the mere presence of the disease. So similarly, the result of this study, the two arms were well balanced, and as expected, and the other important point is that the first line, or the patient who have received one line of a VEGFR therapy like sorafenib, axitinib, has also been allowed in this patient, in this group of the patient. So coming to the result of this study, again, the patients who receive lenvatinib has a clear-cut benefit in terms of the progression compared to the patients who receive placebo. So in patients who receive lenvatinib, the progression of the disease, that means the control of the disease, was close to 19 months compared to the only 4 months. So the hazard ratio, which was 0.6, is further improved in 0.21. So that means around 79% patients benefited in terms of the reducing the progression or death of the disease. So lenvatinib seems to be much potent than the previous sorafenib in terms of the control of the disease. So with this trial, lenvatinib has got FDA approval in a metastatic differentiated progressing thyroid cancer over the other drug. So lenvatinib, so this trial was again a positive trial with a significant p-value and a not only numerically but statistically significant difference in. So practically it's a 6 times the in a placebo, the PFS is around 3.6 months compared to the around 19 months in the lenvatinib arm. So there is a clear-cut benefit of a lenvatinib in a progressive differentiated thyroid radioiodine refractory cancer. So this I discussed with this. And not only the patients, de novo metastatic patient, but patients who received prior 1 line, the PFS was improved. So this means that the lenvatinib was more powerful inhibitor of these pathways. Even in patients who have received 1 line of TKI, the drug did well in terms of the PFS of 15.1 months. Again, as I discussed, these drugs are associated with various side effects, and the main toxicity of lenvatinib is the hypertension, diarrhea, fatigue. So what I was discussing previously, the patients, unfortunately, 3% died because of the toxicity of the drug, which includes the hypertension leading to the brain hemorrhage, the renal dysfunction, proteinuria, which I said. So this slide is showing, although the lenvatinib is very effective compared to the placebo, but definitely it comes with a bag of its own toxicity. When we start, we have to check whether the patient has blood pressure is controlled. On follow-up, we need to check blood pressure every 2 to 3 weeks. We have to start the antihypertensive if the blood pressure goes up. The proteinuria needs to be checked, and we have to definitely modify the doses. So the doses of lenvatinib was 24 mg in this study, but again, with our experiences in the renal cell carcinoma and also in the thyroid carcinoma, it's very, very difficult to reach that dose of 24 mg. Some patient tolerate 16 mg. So ultimately, we have to call these patients, check their tolerance, their toxicity, and so majority of the patient 18 mg, 14 mg. So 24 mg is a dose which is very, very difficult to do in our day-to-day setting. So that means these drugs requires very close monitoring whenever they are being planned or when they are administered to the patient of a metastatic thyroid. So if you see the dose interruption was around 82%. So that what I mentioning that with 24 mg is not possible to maintain the dose intensity. Similarly, in the trial, around 80% patient require the dose interruption. So this number, and this resulted in a mean lenvatinib dose of, so what I told you in our practice, the dose which we use is around 18 mg. So even in their data, the mean dose was 18 mg, and that is the real world practice, that the dose up more than 18 mg is very, very difficult to tolerate, and their quality of life deteriorates. Patients stop taking further therapies. So we have to, so in the practice, we go step up approach, that we start with the 16 mg, see how they are tolerating, then 18 mg. If they are tolerating, then we go up to the 24 mg in day-to-day setting. So I think this we have already discussed, that the 6 treatment-related deaths were recorded on the lenvatinib arm. So we have to be careful that these are the oral therapy, but is not the drug which can be prescribed without proper investigation, proper planning of this patient, and proper instruction given to the patient's family member. So whenever we prescribe any TKI, we tell the family member to monitor blood pressure, come every 2 weekly to show us initially, then monthly, and any warning sign, they have to come immediately to meet us. So just a quick summary that how to select whether the sorafenib is better or lenvatinib, because both are being approved and both drugs have not been compared head to head. So whenever this type of question comes, we see the data of those both the trials, and then we try to come with a meaningful conclusion. We cannot 100% conclude, because for that we need a randomized trial of sorafenib versus lenvatinib, which is not being done and will not be done. So selecting one proper drug which is better is a cross trial comparison, although it's not the thing, but that is the best available thing which we did done in a day-to-day setting. So if you see the select trial, that is for the lenvatinib, prior VGFR were allowed, in decision prior targeted therapy were not allowed. Similarly, the patient treated with lenvatinib not allowed to continue. So when the disease progresses in lenvatinib arm, radiological progression, the investigator have not allowed to continue the therapy beyond progression. While in decision it was allowed to continue, because there was no therapy at that point of time. So they allowed to continue even beyond the radiological progression. Coming to the other important thing, the median PFS was less in the lenvatinib arm, in a placebo group, and that was supposed to be the more aggressive variant, which was slightly higher on the placebo arm of the Nexavar, that is the sorafenib. The other important point, if you compare these cross trial comparison, this lenvatinib versus the decision trial, that is the sorafenib trial, the overall survival, if you see the hazard ratio for overall survival is 0.73. So what I told you, as the hazard ratio, this number comes down, the probability of a drug being more efficacious is proven. So it is 0.73 compared to the 0.88. So if you have to conclude in between these two indirectly, and this side effect profile. So side effect profile of a lenvatinib versus more or less it's talked. The only thing which was more in the lenvatinib is the hypertension, which I told you, grade 3-4 in 44% patient, and the hand-foot syndrome, which is more common in the sorafenib arm. So the lenvatinib causes more hypertension, and the sorafenib causes more of a hand-foot syndrome. So when we finally conclude these two trials, lenvatinib seems to be slightly more effective and better tolerable than the sorafenib for this indication, and it is usually the current drug of choice. Fortunately, the generic brand is available in our country, and even the innovator, the cost is not that high compared to the generic brand. So in a patient in our OPD comes with a differentiated thyroid radioiodine refractory disease who has a progressive disease, lenvatinib seems to be our choice, with a close monitoring of toxicity, starting with a lower dosage and then gradually step up the dose if the patient is tolerating well. So in our practice, lenvatinib seems to be our drug of choice in this group of the population. So for teaching purpose, patients of a radioiodine refractory metastatic thyroid cancer, if patient is asymptomatic or symptomatic, if symptomatic and having a stable disease. So stable disease, that what I told you, that the lung nodule which are being stable, no further increase, asymptomatic, active surveillance, and a cross-sectional imaging at 3 monthly. If stable, then repeat imaging every 6 monthly, and then definitely the periodic thyroglobulin and anti-thyroid antibody, and optional is FDG PET-CT. So patients who have a stable disease, you have to just monitor every 3 monthly initially and then 6 monthly. Asymptomatic patient, if there is a progression of the disease in a scan, if there is a single region, you can consider for local regional therapy like a SBRT or radiofrequency ablation, or a removal of that disease, metastectomy. If there are multiple regions, then the lenvatinib and sorafenib comes. If the patient is symptomatic, a single lesion or local regional therapy. If symptomatic, multiple lesion, then again either a local regional therapy to palliate that, like a patient presenting with multiple bone metastasis with a pain which is not tolerable, then the radiation therapy will be given, and then one of these therapy that I discussed, we prefer lenvatinib. So symptomatic patient, multiple lesion, local regional therapy for palliating the symptom, and then one of the TKIs to be started. So management of asymptomatic versus symptomatic differ. Even in asymptomatic, if there is a progression of the disease, then the role of as I told you, the patient should have a radioiodine. So still the initial part of the management is same: surgery, the radio for the initial for a differentiated thyroid cancer, followed by the whether the patient requires radioiodine treatment or not, then the radioiodine treatment, and on further progression, whether patient is so until unless the patient become radioiodine refractory, still the radioiodine therapy is still the choice of therapy. When the patients become radioiodine refractory, then the role of newer therapy comes into the picture. So that we have to remember, the old is still gold, and this therapy will come into the picture in the latter part of the management. So that was the for a differentiated thyroid cancer. Now we will discuss about the other management option in a especially the medullary sheath thyroid and the anaplastic sheath thyroid. As I told you, these are the although these are the thyroid tumor, but these have a different biology compared to the differentiated thyroid cancer. So as we discussed, the treatment has evolved over a period of time. Similarly, a medullary sheath thyroid, metastatic medullary sheath thyroid cancer, this is the drug and we all know that unfortunately compared to the differentiated thyroid cancer, medullary sheath thyroid cancer has a more propensity to metastasize. So this was the study in a patient who have an unresectable, locally advanced or a metastatic hereditary or sporadic MTC tumor with a good PS. So there was as such no standard treatment for these patients. People used to give chemotherapy, but as I told you, the response of a chemotherapy is very dismal. So by the time this one of the another VGF inhibitor came into the picture, that ventetinib versus placebo, because there was no much treatment at that point of time. So patient of this group, which falls into this patient population, randomized into the ventetinib versus placebo, and it was also a double-blind trial. So that means the patient and the investigator doesn't know whether they are in the placebo arm or a disease arm. That is to prevent the bias in the subsequent, and the ventetinib was continued till the disease progression. Similarly, the endpoint was the progression-free survival, and in a patient who received ventetinib in that group of the population, that means metastatic or a locally advanced unresectable metastatic medullary sheath thyroid cancer, ventetinib benefited in terms of the controlling the disease, and the PFS was not reached. So at the time of presentation of this data, 50%, more than 50% patients are still continued vendetinib, whereas patients who are in the placebo arm, their disease was progressed. So this was the first breakthrough in the management of metastatic. So with this publication of this data in around 2012 and 13, the vendetinib got approval in a metastatic medullary thyroid cancer whose disease progressed over a period of time, and there is no suitable treatment for those group of the patients. And by the time vendetinib came into the picture, there were a lot of toxicities associated with vendetinib, and the another multi-kinase inhibitor which acts on the c-KIT pathway, PDGFR pathway, VGFR pathway, the cabozantinib. So this drug, as I told you, majority of the drugs which are used in the thyroid cancer are already being approved and used in a renal cell carcinoma. So by the time the cabozantinib were already used in the renal cell carcinoma with a good result, with a good VGFR inhibition, then the scientists tried to use this drug in a same patient population in a metastatic medullary carcinoma. So one arm received the cabozantinib and another arm received the placebo, which was the, because as such there was no standard treatment available, and this tablet cabozantinib continued till the progression. Just you have to see in this the cabozantinib dose. It is the 140 mg every day, which will discuss what is the issue with this dosage. So cabozantinib 140 mg versus placebo in a metastatic medullary sheath thyroid progressed over the standard treatment, and there is no standard treatment for this patient at that point of time. So if you see, the median PFS in the cabozantinib arm was around 12 months, and whereas the placebo, so it's a doubling of the control of the disease in a cabozantinib arm. Not doubling, it's practically tripling of the control of the disease in that arm. This cabozantinib benefited both RET mutation positive, where we all know that in a medullary sheath thyroid, RET is one of the major driver mutation. So irrespective of the RET mutated status, whether it was a RET mutated or not, among RET mutated, there are various mutation which you all know, and this is one of the most common mutation, M9180. So this cabozantinib worked all across RET fusion positive, negative, all benefited. So the FDA has also approved this drug for the cabozantinib for. So now the again question comes, among the vendetinib, which is the Zeta trial, and the cabozantinib, which is studied in the exam trial. So whether the vendotinib is better in a metastatic medullary thyroid or cabozantinib. So we again studied the cross trial comparison and see the pros and cons of each trial, and then try to conclude that which one in a day-to-day setting is better. So the same unresectable locally advanced metastatic, and this question is again very important in the medullary thyroid. In a vendotinib study, all patients, irrespective of their disease, whether their disease is radiologically progressing or not, they started the vendotinib. Where in the cabozantinib, there should be documented RECIST defined progression of the disease, then the patient included. So as we discussed for a differentiated thyroid cancer, we all know that medullary thyroid cancer in majority of the patient may have an indolent course, and their disease might not progress that rapidly. The disease may remain in control without any treatment for a sufficient period of time, and whether starting these TKI in that patient will really help, we all know that it might not help. So in cabozantinib, when there is a clear-cut progression of the disease, either a symptomatic progression or there is a radiological progression, then the patient were included. So from the study end point of view, this is one of the important difference between the vendotinib and a cabozantinib, and this seems to be much more or is a better criteria for. So in a day-to-day setting, patient presenting with a liver metastasis, asymptomatic, if the disease is not progressing, we do not jump for starting the therapy. The patient is asymptomatic with a lung mets or liver mets, tiny multiple lung nodule, asymptomatic, we just keep calling the patient, doing a subsequent radiological imaging. When there is a clear-cut radiological progression of the disease, then we start the treatment. So from that point of view, the cabozantinib trial was seems to be much better. So the toxicity, the same, any VEGF inhibitor. So discontinuation due to adverse event was seen around 16% patient, and in the 12% patient. So from the study design point of view, we feel that cabozantinib was a much better design compared to the vendotinib. Unfortunately, this drug is not available. It is much toxic. It's not available in India. So we have only one choice, and which is the better choice. So cabozantinib is being used in day-to-day setting. But only thing is the dose which was used in the 140 mg. And from our experience, what we can say that cabozantinib beyond 40 mg is a very, very difficult drug to tolerate. So in the same fashion, in the lenvatinib, we go for a step-up design, a step-up approach. We start with the 40 mg, call the patient every 2 to 3 weekly, and then in a 4-week time, we decide to go to the 60 mg. But in my personal experience, I have not been able to increase the dose beyond 60 mg. So although the approved dose is 140 mg, but it's not possible to reach to that dose. But compared to the vendotinib, cabozantinib is much more potent and is being commonly used in a metastatic medullary thyroid cancer, which is progressing. That point is very important to understand. So this was the traditional targeted therapy era. As the science has improved, newer targeted therapies has come into the picture, and the most important and the number one player in the this is the RET mutation, which we discussed. So if you see the various mutation profile in a papillary thyroid cancer versus the medullary thyroid cancer, this is the mutation profile in the medullary thyroid, and this is the papillary. So in a papillary thyroid, 60% will have a BRAF mutation, and the RET fusion is seen in 7%, and NTKRK, which I will discuss, NTRK fusion, and in rarely other uncommon mutations. So that means the in a papillary thyroid patient progressive disease, the around 60% will harbor this important mutation BRAF, and around 7% will harbor the RET fusion. When we see the medullary thyroid, the RET mutation number increases significantly. Around 50% patient will have some or other type of somatic RET mutation. If you see the difference in a medullary thyroid, it's the mutation, RET mutation, whereas in the papillary, it's the RET fusion, which we will discuss in the subsequent time. So for a targeted treatment point of view, majority of the papillary thyroid can, if we have an inhibitor which blocks this drug, we can give this treatment to a significant proportion of a papillary thyroid on progression. Similarly, if there is any drug which which inhibits the RET mutation, we can offer in a progression to in a medullary CA thyroid cancer. So, and the other important point in discussion are these mutations are static. So at the time of initial surgery, if we do a tumor mutation profile, that will be different. When the patients become radioiodine refractory, the mutation profile is changed. So this is one of the graph which is showing that the how tumor mutation profile over period of time. So if you see the BRAF mutation in patients who become initially the radioiodine refractory, only 9% initial progressive disease, only 9% will have a BRAF mutation when they planned for a radioiodine therapy. But after the radioiodine therapy, the tumor further escapes, and the BRAF mutation number, which was 9% initially, will increase in this study 26%. So that if you do a mutation profile study at this point of time, you might not be the might not detect the BRAF because seen in only 9%. But as the patient become radioiodine refractory, the percentage will increase. And this, so that is the reason in today's era, when the patient progresses, we want a repeat biopsy to assess the mutation profile, which is a dynamic thing. What I meant that if you want to study the current mutation profile, if you do a biopsy, a mutation study from a baseline block, you might not get the reduction. So that is the reason, if patient is affording, they want to explore the newer option in a progressive disease, we usually consider for a new biopsy and then send the tissue for a NGS study today, because this mutation profile changes over period of time. So as a surgeon, whenever call comes to do a repeat biopsy of a lymph node, there that is the logic, or that is the reason we want a repeat biopsy for this tumor. So coming quickly to the RET gene, so a RET mutation, so it's located on the chromosome 10, and this is the transmembrane receptor, and this there are various domains, and as per the various diseases, the papillary and the mutation, that we will discuss how this changes over period of time. So that what I discussed in a thyroid cancer, the RET fusion and RET mutation. So RET fusion is mainly seen in a the differentiated thyroid cancer, whereas RET mutation is seen in a medullary thyroid cancer. So whenever we send the tissue in a medullary thyroid cancer, we ask for a mutation, and when we send the tissue in the differentiated thyroid cancer, we ask for the RET fusion. And I told you that hereditary may have, sporadic may have a 50% chance, and a hereditary, the chances of RET mutation increase to close to 90%. And as we all know that all medullary thyroid patients should have a RET testing and should have a genetic counseling to get this mutation profile testing. It's not only for the familial aspect from the what we call as a prophylactic thyroidectomy, for even in individual patient, if we get a RET mutation, they are affording this drug, works very well. We have although it's not available right now in India, but in few patients who exported this drug outside, it's a wonderful drug. It's a very potent inhibitor, and the disease control is much better compared with the other TKI. So just a quick, this is the study. If somebody is interested, the Liberto is the trial where this salpercatinib is used in this patient. So patient of a RET mutation positive, one arm received the standard of care, either cabozantinib, which was approved at that point of time, versus the salpercatinib. So in a RET mutated tumor, salpercatinib, the control of disease was much better compared to the cabozantinib. So with this laboratory trial, if patient is affording for salpercatinib, if there is a RET mutation, we should prescribe salpercatinib, not the cabozantinib, because if you see the control of the disease practically flattening compared to the patient who received the cabozantinib, and see the hazard ratio of 0.28. So there is no doubt with this trial data that RET mutation positive patient affording on a progressive disease should be offered salpercatinib over the cabozantinib or vendatinib. Similarly, in a differentiated thyroid cancer where the fusion is positive, the control of the disease was better in patients in a second line when they receive the salpercatinib. So initial was the medullary thyroid, and this graph showing the benefit of this drug. So if you see the benefit, it's the benefit was more seen in the papillary thyroid compared to the other variant of differentiated thyroid cancer. So in a progressive disease is progressing over the standard line of treatment. even in a differentiated thyroid cancer, we should test the red fusion, and if positive, we should offer them. So with this these two data, the FDA has approved sulfacetinib, and that is the another red inhibitor pralasetinib. These are the two red inhibitors. So in patients of advanced or metastatic red mutant MTC who require systemic therapy, similarly advanced or metastatic red fusion positive differentiated radioiodine differentiated. So both medullary thyroid and differentiated thyroid, if their red mutant positive disease is progressing, this is one of the standard treatment. And in the next few months, I think the drug maker, the Lilly, is marketing this drug in India. So by this year end, we may have an option of using this drug for in our own. Those who are affording, we export this drug from outside. Definitely, the cost is a major challenge for using sulfacetinib in our patient population. But I think due course of time, we can use this drug when it is available. So the same is for the BRAF. I told you that majority of the differentiated thyroid cancer has a BRAF mutation. So this mutation is also commonly seen in the malignant melanoma. So by this time, the BRAF inhibitor will already use in the malignant melanoma. When people find that this mutation is also seen in a papillary differentiated progressive disease, they try to use this drug. So this is the just showing the percentage of patients who have a BRAF. So that I told you. Another is the low-grade glioma. So all the melanoma more than 50%, anaplastic thyroid cancer around 20 to 50. So these are the tumor which rarely can have a BRAF V600E mutation. And in a like a lung cancer patient, we test with for this also. Fortunately, the frequency is only 1 to 5%. But if any patient will get this mutation, we can have a targeted therapy. But in anaplastic thyroid carcinoma, this number is close to 50%. Similarly, the response for these therapies is in anaplastic is around 53%. So that means if we target this mutation with a specific drug, the disease gets controlled for a sufficient time, a meaningful control of the disease with this. So the drug which is being used in this group of BRAF V600 is the dabrafenib and trametinib. So it's a combination of these two drugs which have shown benefit in blocking this pathway, the dabrafenib and trametinib. Fortunately, this combination of drug is available in our country. And if you see the CR rate, this is a water forest plot showing the response of this drug in a BRAF mutated tumor. So quite and this is the percentage of tumor shrinks. If you see, the majority of them patient will have a more than 30% shrinkage. And if you take the 50% shrinkage, around 50% patient of a BRAF mutated tumor, when you use this drug, majority of them will have a shrinkage in tumor, and some will have a total control of the disease for a sufficient period of time. So with this data, the BRAF P600E mutated thyroid cancer, whether it's a papillary tumor, whether it's an anaplastic tumor, in a second line therapy, when disease progresses, we have one option to offer this patient, and these are detected either by a RT-PCR, that is a targeted sequencing, or in today's era when we send the sample for a NGS, that is next generation sequencing, which detects all the mutation in a given tumor. And as I told you, we prefer a new sample or at the time of progression rather than the baseline sample. So just a quick review, as the immunotherapy has emerged deeply in the management of a various cancer in our field, and has successfully established its role in a melanoma, thyroid cancer, lung cancer. And we definitely can say that the survival for these patients has improved with the use of immunotherapy in those group of the patient. So with the same data as this, in majority of the patient, when disease progresses, the investigator tried to use this immunotherapy in a thyroid cancer, progressive thyroid disease, and they want to know whether the immunotherapy is efficacious in that pattern in a various thyroid tumor. So just a quick pictorial diagram. So what we all know that our body has a capability to tackle any of the external antigen or a mutated cell in the body. So this is just to show how the immunotherapy works. So this is the tumor cell, and this is the T cell which is designated to kill the, because this tumor cell has a different antigen, the immune system will recognize this tumor cell as a foreign cells, and the T cell is stimulated to kill this tumor cell. But what happens during the tumor pathogenesis? These tumor cell will harbor or will develop some receptors, what we call as a PDL1 receptor, which will inhibit the activation of these T cells. So these T cells are designated to kill the tumor cells, but with the inhibition of this T cells by the affection of this PD1 with PDL1. So whenever the tumor cell expresses the PDL1 on their surface, the T cell which has a PD1 receptor, so this binding of PDL1 receptor on the tumor cell and the PD1 on the T cell, this will lead to energy or the silencing of the T cell. If we block this pathway, if we give some inhibitor which blocks the PDL1, so this binding will not happen and the T cell will remain active and will kill the tumor. Similarly, if you give any drug which binds the PD1 on the T cells, then the PD1, PDL1 inhibition will not be there and the tumor cell. So this is one of the basic mechanism. So there are two types of inhibitor in immunotherapy. One is the PDL1 inhibitor, which is present on the tumor cell, and another is the PD1 inhibitor, which is present on the T cell. And there are other co-stimulatory molecule, and the most important one is the ipilimumab, which inhibits the dendritic cell activation. So immune complex is a very complex mechanism to understand. In a simple word, the body normal defense tries to kill the tumor cells, but with the availability of the various checkpoints in the tumor cell, these T cells function is get inhibited. When we give some inhibitor, the T cell will remain in a activated way and kill the tumor cell. So this is one of the physiological mechanism how this. Now the same phenomena comes into the in various thyroid cancer. So majority of the trial which is done in immunotherapy in a pembrolizumab, this is one of the immunotherapy keynote name. So in a basket trial of various differentiated progressive thyroid cancer, anaplastic thyroid cancer, they tried to see in which group of the this work. So in another the like a differentiated thyroid cancer, pembrolizumab is being tried single agent, nivolumab, which is the anti-PD1 with a CTLA4 inhibitor. So these are the various trials which have been done, and various trial is still ongoing in the literature to see the efficacy. So at this point of time, we generally consider using immunotherapy, and in the last, and is there any receptor or marker to understand whether in which patient these immunotherapy work? So one of the common marker which is being used in the day-to-day practice is the MSI. So in patients with the tumor harboring this MSI high or deficient MMR, there is a clear-cut benefit of pembrolizumab. Similarly, if there is a ROS1 or ALK mutation, although it's not very common, but if any patient of a thyroid cancer harboring the ALK or ROS fusion, we have a drug which can be used. So this slide is showing the management of a metastatic metastatic thyroid cancer has evolved. One side doesn't fit all, and the various targeted. So this is the last and concluding slide, that with the availability of the newer therapies, various receptor tyrosine kinase inhibitor, which blocks different pathways, which is mentioned in this VGFR, KIT, lenvatinib, another the FGFR. So these are the various targeted therapies which have been available for managing the metastatic progressive thyroid cancer. Either it's a medullary, either it's a differentiated, either it's an anaplastic. The other thing which is coming in big way is the cancer vaccine, which is in next few years we will definitely have the newer data. And the what we call as a peptide receptor radionuclide therapy. It is one of the targeted therapies in some of the medullary CA thyroid patient and very few of the differentiated progressive thyroid patient. When the disease progresses, their surface expresses the somatostatin receptor, and at that point of time, if we do a DOTA scan, if we find that there is a good expression of the DOTA in their surface, we can use the, so it is one of the targeted therapy. If there is a DOTA expression, we can consider for PRRT in this. Similarly, the immunotherapy, I told you, this is just the beginning. And in anaplastic shear thyroid, where there is a high expression of PDL1 in their subregion, we have some phenomenal response. So in patients who are affording progressive disease, limited options, accepting the toxicity of this drug, especially the immunotherapy in anaplastic shear thyroid, we have seen very good promising results. So in conclusion, the management of a metastatic CA thyroid has progressed beyond the conventional chemotherapy, beyond the conventional targeted therapy, with the availability of the newer and newer agent. The survival and especially the quality of life for those metastatic patients has improved in this group of the setting. And definitely the road has not the pathway, the journey has just begun, and we have much better targeted therapy which is on the verge of approving in this setting, and the survival of this patient is going to improve. But in the last, still the standard treatment for a day-to-day case is still the surgery followed by the for a differentiated thyroid cancer, surgery followed by the radioimmunotherapy. The radioiodine therapy is still the standard of care. Unfortunately, 20-30% which progresses, these are similarly for a medullary thyroid. Proper surgery is still the gold standard, and these therapies are for those, unfortunately, in those patients disease progressive, then we can use this therapy. Only thing is that in due course of time, the new adjuvant approaches for these tumor is still in an experimental way. Various trials are all going with the use of these therapies in a new adjuvant setting, whether to reduce the tumor bulk to make them operable, but still all these are experimental. In due course of time, there might be some data regarding the use of this therapy as a new adjuvant or as an adjuvant to prevent the further recurrence of the disease. Thank you. Thank you for your patient listening.
So thank you, Dr. Amit, for quite a comprehensive lecture, wonderful one. So I think if you could tell us a little bit about the neoadjuvant role. Are we in a stage where we can send our patients who are advanced differentiated thyroid cancers, sometimes like involving the TO group, or advanced where we know that will not achieve R0 resection? So what is the evidence and what is your practice?
I think if you ask, do all patients of a thyroid cancer need some sort of a neoadjuvant? No, the answer is no. If it is an operable tumor, surgery is still, as I told you, surgery is still the gold standard. In a rare cases where the extent of the surgery or very, very morbid, and where we are not able to go for a resection, a safe resection in a what we call as a, after discussing with the patient, their family regarding this, we have used in few patients. And what we can say from our experience, that in patients who are not resectable at that point of time with this targeted therapy, some have responded well and ultimately become. So at this point of time, it is still in a case-to-case basis. When you feel that a very morbid surgery, like a patient presenting with a multiple lung metastasis, where the patient general condition is not fit to undergo a thyroid surgery, so that we have tried in few patients to buy the time, let the patient respond to the therapy, let their general condition improve. So in those scenario, in a case-to-case basis, this can be considered, but not in a run-of-a-mill cases.
So I think there is a question that is this applicable for refractory nodal disease in the neck, or surgery is preferred?
Again, if the node is removable, surgery is possible. It is not encasing the major blood vessels or underlying structure. If we are able to get a good R0 resection or R+ resection in a differentiated thyroid cancer, we can have not used radioiodine previously. Still, I will feel that the surgery followed by radioiodine will be the first treatment. In cases where we are not able to resect the majority of the tumor, where radioiodine is not going to helpful, in those selected cases it can be considered, but not the first will be the surgery will be the first choice even in this scenario.
So I agree with Dr. Amit regarding the surgical part, that whenever resectable, we have to go ahead and remove the tumor. Second is, even if we achieve a R+ resection, if it is especially against the trachea, where it will make a difference in the outcomes, especially that you need a tracheostomy later on, or because there are adjuvants in the form of RAI and sometimes even EBRT to support that. I think there we have to go ahead and remove the disease. Last question, Dr. Amit, that how in a population in India where like center like Tata Hospital also, where majority of our especially head neck patients belong to a lower socioeconomic status, how relevant are these therapies, the targeted therapies and the immunotherapies for our patient? Can you just tell us just basic idea that how costly it is for our patient who are metastatic if you are giving targeted therapy or immunotherapy vis-a-vis response also?
So I think with the availability of the various generic drugs, the cost of all targeted therapies, whether you will ask for a lenvatinib, whether you ask for a sorafenib, or other TKI like sunitinib, exitinib, all have come into the monthly range of 5 to 6,000. So compared to the previous majority of the patient, we are able to offer these therapies. The only thing which I told you, the toxicity of these drugs, although these are oral tablets, but these needs to be monitored very closely because of the toxicity associated with this therapy. Regarding the response of this treatment, majority of the patients, so if you see the response, it's close to around 30-40% patient will have a shrinkage in the tumor, and the control of the disease in terms of the PFS and OS, it is similar to what we've seen in the data. So cost is not a constraint. All these are comes within the range of 5, and since these drugs are at this cost, this at least in the various national what we call as a program like Ayushman Bharat and all that, so these are 5-6,000 is easily covered with that. The only issue is regarding the immunotherapy. So in a squamous cell carcinoma, head and neck, we have seen that even low dose immunotherapy works. So in a patient who have a very high PDL percentage, have a MSI, a high tumor, where we want to give them the immunotherapy, the low dose immuno can be, although it's not studied in this patient population, but we can extrapolate and consider for, and the cost of a low dose immuno for a 20 mg will be around 20,000 per month. But and the patent of immunotherapy, and in next 1.5 years, the patent will go off, and so similarly the cost will come down in due course of time. The only thing which is relevant is that in a affording patient, in a progressive disease, we have to offer them the NGS testing to know whether there is any driver mutation, driver targetable. Even if you have a driver mutation, if it is not targetable, there is no benefit of that to the patient. To the science, it may benefit. For a patient, if there is a mutation which is druggable or targetable, then that will definitely benefit the patient. So in a affording patient, in the current era, on progression, general condition is good, we should offer them NGS to know whether there are any targetable mutation is there or not.
So thank you, Dr. Amit. I think that was a very important point that as I think most of us surgeons, we are not sure about the cost of the targeted therapies because we have been always like this idea that they are quite costly. If this has come down so drastically, I think it is, I think should be part of our treatment protocol that whenever we have radioiodine refractory differentiated thyroid cancers, we don't have any options left. Like any further treatment, surgical or otherwise, I think taking an opinion or a reference to a medical oncologist is a good idea, as well as for the medullary as well as anaplastic. I think with this, if there are no more questions, we will conclude today's lecture. And we thank you once again for a wonderful lecture.
Thank you. Thank you all.